thanks for everyone for joining us tonight. What I hope to cover tonight is my experiences using the EMS high-powered laser, which is I've had the privilege of using for the past 6 months, and I wanted to use it in clinical practice before presenting publicly on it, so I could really see how it fits into clinical practice, how it fits into my clinical practice, and how I could sort of integrate it. What sort of patients was I getting the best results from? We're then going to talk about a new innovation from EMS, which is the guided Doppler class therapy, or GDT. And this is really a framework that allows clinicians to improve the outcomes with their patients using a framework that integrates electrophysical therapy along with evidence-based medicine as well. I'm going to talk a little bit about how high-powered laser can be utilized on its own for treating certain indications, and when it would also be worthwhile combining it with Doppler class, because it is designed to be combined for those indications as well. And then we'll run through a few case studies on some of the interesting patients that I've had using laser. So firstly, the EMS high-powered laser, it uses a 905 nanometer wavelength, which is super pulsed. So the laser pulses are, they're up to 300 watts of power, which is very powerful. But the super pulsed means that they're only in the realm of nanoseconds. So the laser is delivering thousands of pulses for every second. And the 905 nanometer wavelength is within what we consider our therapeutic window, that the literature over the past sort of 3 to 4 decades has indicated and shown to have an effect on nociceptive pain and inflammation. And I think laser can be in particularly useful for neuroplastic pain, which I'm going to cover in a bit more detail further in. The high-powered laser allows you to increase the penetration of that laser so that we can treat deeper indications. And it also allows a faster treatment time, because the main thing we're really focusing on is, when we talk about dosing of therapeutic laser, it's generally considered, we're looking at sort of watts per centimeter squared. So we're able to cover a larger area combined, in comparison to something like a low-level laser therapy. The laser is able to penetrate up to 12 centimeters, which is really impressive for treating some of those deeper indications that we can have trouble getting to, particularly even with manual therapies. So going through some really basic laser physics, photons or light occurs within the electromagnetic spectrum. Now, below 400 nanometers, we're in that sort of ultraviolet range. The visible light ranges between 400 and 770 nanometers. And laser has been shown to have a therapeutic effect within between 650 and 1350 nanometers. So that's really what we consider in laser the therapeutic window. Now, different wavelengths of light will have different absorption of water, melanin, and hemoglobin. So the reason the 905 nanometer wavelength is important is because it has low absorption of water and melanin and hemoglobin. And this is important in order to deliver the energy to the required depth. If we have high absorption of water, melanin, and hemoglobin, the energy is going to be absorbed superficially. That's going to turn into heat, and that can potentially cause tissue damage. But in particular, the higher the absorption superficially, the less energy that is able to reach those deeper structures. So if you have a look at the graph over here, we can see that we have quite low absorption of these structures, because these are not our target. We're not targeting water, melanin, and hemoglobin. We're targeting the cells themselves. Okay, so really the formula, and a lot has gone into, the laser is developed on sort of 30, 40 years of research, looking at what sort of protocols and what sort of parameters provide the best therapeutic effect. We are not trying to create heat in the tissue. What we're trying to achieve is photobiomodulation, whereby we use light or photons to cause a modulation of biological function. This is no different to, think about how natural sunlight can help our bodies synthesize vitamin D, how plants are able to, through photosynthesis, produce energy. We're looking in that same sort of realm. So remembering the 905 nanometer wavelength is important for two reasons. One, it's within the therapeutic window. And secondly, it has low absorption of water, melanin, and hemoglobin, allowing for that depth of penetration. The high peak power also allows for optimum tissue penetration, and the short pulse time in nanoseconds does not allow a burning of the skin. Because, for example, my experience with laser, I use laser, a 10 watt diode laser, and I use that for cauterization for wart surgeries and things like that. Now, that's only using 10 watts, and that will, when it's in a focused point, can cauterize tissue and vaporize tissue very rapidly. Now, this is using 30 times the amount of energy, but because of the combination of the high peak power with the short pulse duration, we don't create the same we don't create tissue injury. So it's really engineered to maximize the depth of penetration and also maximize tissue safety. So what I'd like to talk about before we move on to really some of the research behind laser is just a recap of the pain pathways, because this has, I think, a significant impact in terms of how we utilize laser in practice. So let's take the example here. We've got a noxious stimulus, which is a needle, which has pierced the finger. Now, this is going to cause two things to occur. First, it's going to cause damage to cells, and damage to cells results in the breakdown or the synthesis of arachidonic acid from the cell membrane, which is then broken down by our COX enzymes, and in particular our COX-2 enzyme, to prostaglandins and bradykinin. Now, these pro-inflammatory cytokines have the effect of causing sensitization of the pain receptors, those unmyelinated C fibers, and the actual injury itself will also cause a depolarization of those pain nociceptors. That's going to be transmitted, or you're going to get transduction along our first order neuron through the dorsal root ganglion, where it's going to synapse with a second order neuron, and it's going to cross over. That's going to make its way up to the brain via the spinothalamic tract, and it will reach the thalamus, and the thalamus is the relay center, and this is going to divert that impulse towards the sensory cortex. And the somatosensory cortex is a little bit like a map. It's that homunculus man that you see where it's got very big hands and very big feet. And this map is basically a map of our where our sensation is occurring from, so that we can locate where that pain is occurring. Now, our brain and that message that makes its way up to the cortex is not pain. That's really a warning signal. That is a warning of either actual tissue damage or potential tissue damage. Our brain has to interpret the environment that this is occurring in. And it then has the ability to either upregulate or amplify that pain signal, or turn the volume down on it. And we know that what can happen is, in particularly when patients are immobilized for prolonged periods of time, that somatosensory cortex, or that map, starts to become a little bit blurry. And this is from some of the newer neuroscience research, where when you're in good shape and you're using your hands a lot, you're exercising, you're active, you're using your various body parts, that somatosensory cortex is really sharp and crisp. When someone has a chronic injury, that becomes a bit blurry. It's harder to localize where that pain is. And when that message is a bit blurry, the brain will tend to amplify or turn the volume up on that pain signal. And that's generally what we would refer to as CNS, or central nervous system sensitization, where they're becoming more sensitized to it. The descending modulatory pathway basically comes down and it reaches the same synapse where our afferent impulse goes up. It has the ability to stimulate the interneuron, which can produce endogenous endorphins like enkephalins. And these have the ability of down-regulating that pain signal. But it can also increase that pain signal. And we know there are various risk factors that can occur in terms of some patients are more likely to develop chronic pain. And these risk factors include age. So people who are older are more likely to develop chronic pain. It's more common in women as well. And it's more common if the patient has an underlying mental health diagnosis, such as anxiety or depression. People with chronic pain, over half of them will have depression, and that depression will be listed as severe. Unemployment is another risk factor, or unstable employment, having an elevated BMI or obesity, low level of physical activity. Smoking will increase that risk of developing chronic pain. Surgery, and particularly if the surgery has resulted in a post-surgical complication, patient will have an increased risk of chronic pain. And socioeconomic status is also inversely related to chronic pain. So a lower socioeconomic status is also a higher risk factor for pain. Now, this is important when we move on to understand where I see how useful laser can be in terms of clinical practice, because our laser does have the ability to down-regulate that input into the pain pathway. And I think this can have a profound effect on implications in terms of chronic pain and also acute pain. So in terms of, this is an interesting research that looked at the microdialysis of an Achilles tendinopathy using laser. So the way this research was conducted was they selected people that had bilateral Achilles tendinopathy because the patient could be their own control. One Achilles can get the laser and the other one gets the control. So we had 7 patients, 14 tendons, and it's double blinded. The patients didn't know whether they were receiving laser on which tendon, and the clinician who was administering the laser also didn't know. Because the 904 nanometer wavelength occurs in the infrared range, it's not visible to the human eye. So the laser, even the EMS laser, it is not visible, the actual laser that's being used for treatment. All lasers will have an aiming beam, which allows you to see where the laser is aimed at, and this is for safety reasons, but that is not within the therapeutic window, and it's a very low energy, like a laser pointer, just so you know where the laser is. So the clinician and the patient were unaware. A small catheter was placed into the intratendinous area, and this allows for the sampling of the fluid. And what we're interested in this case is the concentration of prostaglandin E2. So if you remember from your physiology and microbiology, when the cell membrane is damaged, it causes an activation of that inflammatory pathway. Arachidonic acid is synthesized, which is then broken down by our COX-1 and our COX-2 enzymes to form prostaglandins, bradykinin, and other pro-inflammatory cytokines. These pro-inflammatory cytokines have the ability to cause sensitization of the nerve fibers locally. And what that means is that it lowers the threshold of depolarization before that impulse is generated. So what we can see here is when we're measuring this, each of these time periods is 15-minute time intervals. So in the first hour, we don't see a whole heap happening. But after about an hour, we start to see a significant decrease in the concentration of prostaglandin E2, that pro-inflammatory cytokine, which we start to see occurring from about the 1 hour mark. Whereas the control group, that's progressing sort of upwards and not changing very much. So we can see in this research, it's sort of demonstrating some of that mechanism behind how laser can modulate the inflammatory pathway. This is also an interesting piece of research that is out of Japan in 1994. And what this looked at is the effect that laser had in terms of achieving a selective neural blockade on the unmyelinated C fibers and A delta fibers. So remembering that our C fiber is often responsible for pain, and the A delta fiber is responsible for things like cold and hot. So in this research, they used rats, and the rats had a little electrode placed into the sciatic nerve, which could monitor, like a nerve conduction study, the impulse, and various stimuli were applied to the paw. So the control group, we can see the first thing that they did was brush, and we can see an impulse that's generated from that. Pinch, which really represents sort of pain to a degree, and the stimulation of that C fiber. Cold and heat as well. After 3 minutes of irradiating using that 905 nanometer wavelength, we can see that brush hasn't been affected very much. And that's because brush is not a pain response. It's not occurring through the C fiber. But we do have a significant diminishing effect on pinch, cold, and heat. So laser can have an effect, and there's other research that's shown similar results. It has the ability to disrupt and modulate that pain response. So it's been discussed as creating almost a 30% reversible neural blockade. And this can have significant implications for acute and chronic pain. Okay. So now I'm going to introduce the guided Doppler class therapy known as GDT. And this is an innovation from EMS that's been sort of recently released in combination with the laser. And what it provides clinicians who are users to provide a framework to maximize the outcomes that you get with your patients, utilizing these electrophysical modalities and combining that with an evidence-based approach. So the first stage of GDT protocol is no different to what you would otherwise do as a clinician, which is to assess and engage the patient. And we really encourage the use of objective measures such as the visual analog scale, range of motion testing. And this helps to formulate a baseline to which you can develop a treatment plan. It's very difficult to set expectations with patients if we don't know where we're starting from, and how do we evaluate how successful the treatment has been. Just recapping some of the contraindications. So the contraindications for laser include treatment over neoplasm or cancer, treatment in pregnancy because it hasn't been tested in pregnancy, treatment over an implant such as a pacemaker or other metallic implant, and direct treatment over tattoos. Because tattoos are of a different pigment, different color to the skin, they can absorb that laser light at a higher rate, and that can cause heat or a burn to occur. So we don't treat directly over tattoos. The Shockwave contraindications include treatment over the lung or the gut or air-filled spaces, pre-ruptured tendons, pregnancy, the treatment in patients under the age of 18, unless it's for Osgood Schlatters, which is an indication, the treatment of patients who have blood clotting disorders, including DVT, also patients who are treated on oral anticoagulants, such as warfarin, Plavix, those type of medication, because we can also, again, treatment directly where the tissue may have a tumor or bacterial infection, and treatment of patients who have received a cortisone injection within the past 6 weeks. Okay, so this is really going through the decision-making tree in terms of how do we work out when to use laser, when to use shockwave. The primary indication for using laser is pain and inflammation. The primary indication often for Doppler class shockwave is tendinopathy, fasciopathy, trigger point therapy. They're some of the more common indications that we're going to use in musculoskeletal medicine. So the first question is really, how long has the patient been suffering with pain? If we're dealing with pain that's sort of less than a month within that acute frame, we first ask, are there any contraindications to using laser? If there is a contraindication, we obviously find a different treatment for the patient. If there's no contraindication, then we can utilize our laser. And the laser's been developed with many protocols. So there's protocols for analgesic effect. There's also specific condition-based protocols for, plantar fasciosis, for lower back pain, for bone marrow edema, and so forth. So there's a lot of has gone into developing the right sort of protocol with the right amount of energy and the right parameters that have been set based off known research. If the pain is more chronic and it's been, over a month to 3 months, we're starting to consider this as sort of a subacute or chronic. Firstly, is there an indication to use shockwave therapy? So do we have a patient that has a tendinopathy or a plantar fasciitis or, again, an indication to use our shockwave device? If there is a contraindication to using shockwave or laser, we obviously find a different treatment modality for them. And if there's no contraindications, we really try to work out, and this comes down to setting expectations with the patient. What really do they expect? Is this a high-level athlete who just wants to maximize and get back on field as soon as possible? Or is this someone who is less worried about it and they would like some treatment? It's about really working out with the patient what sort of amount of intervention do they want. So firstly, if it's more of a standard response, we can treat again just with shockwave on its own. The other option is utilizing the laser first. And by utilizing the laser first, we then wait 5 minutes after the laser treatment. And we know that after about 5 minutes is when that analgesic effect is starting to take effect. We're getting some of that neural blockade of the nociceptive fibers. So this helps with the tolerance of shockwave therapy, meaning that we can deliver more energy. And we know from some of the research, in particular around osteoarthritis of the knee, we know that the results are correlated to the amount of energy that we're putting in there. So if you have a patient who's very hypersensitive to shockwave and has difficulty tolerating it, and this can be more problematic in the early stages, utilizing this approach can help those patients tolerate the shockwave. And obviously, if we can get more energy with the shockwave device in there, we're going to improve the outcome. If we really want the maximum results, this is where we take a slightly different approach. So we treat the patient using either the GDT protocol, which is really a 3-minute protocol, or we can even use a longer protocol. We then combine this with some rehabilitation. So we combine it with rehabilitation and we wait up to an hour before we utilize shockwave. And the reason for doing this is because by lasering first, we're helping to modulate that pain pathway, allowing the patient to, move through different ranges of motion. It's allowing for that ambulation and mobilization if needed. Like if the patient is really having trouble with movement, laser can have an effect there. So we get we're able to do more in terms of rehabilitation. We know that moving that segment, moving the hand, moving the foot, moving is medicine in itself. We then wait up to an hour, and the reason for that is because that's when we're going to start to see the anti-inflammatory or the modulating effect that the laser can have on the inflammatory cycle. And we wait up to an hour because of the previous research that we've just sort of discussed. This is running through, again, some indications and how this works. So considering this custom GDT approach utilizing the laser, that 905 nanometer wavelength has an effect on nociceptive fibers. And this starts to kick in after 5 minutes. And can last up to 72 hours. So in general, if we're using laser as a standalone treatment, we generally need, and the sort of protocol that you'll tend to use is I'll use 3 sessions a week for 2 weeks, and then 2 sessions a week for sort of, up to 4 weeks. So laser does take a bit more time with patients as a standalone treatment. However, when you utilize the GDT approach for Achilles tendinopathy, we don't need to see the patient as frequently because we're utilizing a multimodal approach. The shockwave and the laser both have different effects on the tissue. We also know that after an hour, we're going to start to see some of those modulatory effects in terms of the inflammatory cytokines that are going to be seen locally. This again feeds back into the patient's pain because if we have a higher concentration of prostaglandin and pro-inflammatory cytokines, this is going to cause sensitization of those nerve fibers peripherally at the site of injury. This means that those patients are going to be more likely to experience pain with things that didn't typically cause pain on the uninjured side. Our shockwave has that effect. We have several effects there, and it's very similar for either focus shockwave or radial shockwave. We see some effects again on pain and that desensitization of the C fibers, and that analgesic effect also can kick in very quickly with shockwave. So patients get up from treatment and they generally will say, wow, that feels a lot better. I have less pain now than I had before the treatment. We also know that shockwave is going to release other growth factors that can be important in angiogenesis and also the activation of mesenchymal stem cells to create new tissue. So engaging with patients is really important, as it's extremely important in healthcare, as you're all aware, and it's taking time to actually explain the pathology to the patient and also explaining in simple terms how things like the laser works, how the shockwave works, and how this may help with their outcome. It's important to never assume that the patient knows what to expect with treatment. If you don't have this conversation with patients and set the expectation with them, what will tend to occur is you'll set your own expectation. The patient will set their own expectation. And if they're expecting, they may have a significant injury, and if they're expecting that they're going to be, 70% better in 2 weeks of treatment and that hasn't occurred, they're going to be disappointed. So it's important to have those conversations up front with people because setting expectation does play a significant role in terms of the patient's outcomes. If the patient has suffered with chronic pain for a very long time, it's important that we sort of set the expectations with them. What do you see as a clinician as being a good outcome, and making sure that matches with what the patient sees as a good outcome? One of the things that's most common following surgery, and I've had many patients over the years who've presented complaining that they weren't happy with the surgical outcome, and particularly around things like bunions. And you look at the x-ray, you look at the foot, you look at the alignment, and so forth. And in some cases, yep, they've had a poor surgical outcome. There's poor surgical techniques, they've had a complication. In other cases, the surgical technique can be spot on and perfect. But the patient went into this surgery with different expectations than the surgeon had. So the patient went in there because they had an arthritic big toe joint and they wanted to wear high heels. The surgeon might have, he or she may have wished to just make the joint move a little bit better and hopefully reduce some pain. I've had other patients that had their bunion surgery because they didn't like the appearance of it. They work and they wear corporate shoes very frequently. Surgeon has opened the joint up and seen there's advanced arthritis, and they've performed a fusion, which means that the patient now can't bend that big toe joint, and that creates implications for footwear. In many of these cases, there is a difference in expectations between the practitioner and the patient. It's important that you have these conversations. So we then can utilize our high-powered laser, and we can utilize this in in more of those acute settings where we're trying to have an effect on pain or inflammation. One of the caveats I'd make in terms of just using, in clinical practice, I don't just use a standard approach to if the pain's longer than 1 month. You have to take into consideration their presentation, because you can have circumstances where you have an acute on chronic setting. And I treat that a little bit different. So someone can have, say, heel pain for six months. They've got a mild sort of plantar fasciopathy. And then all of a sudden, there's a sudden escalation in their pain. And these sort of patients will present often limping as they come in. The pain went from being very stable, and that typical post-static dyskinesia, pain first thing in the morning that reduced as the day went on, pain after rest, to more consistent throughout the day, and sometimes even some nocturnal pain. And having diagnostic ultrasound in the clinic, I will scan all of these patients, and you'll often find that there's been an intrasubstance tear that's developed. And now they have more of an inflammatory process there. In these patients, even though the pain might have been 6 months, I will tend to then use the laser and things like strapping and bracing and things like that to try and reduce the inflammation and the pain and get some healing to occur, and then utilize Shockwave later. So it's not a clear-cut rule. As a clinician, you still have to use your clinical judgment. We then can utilize our radial shockwave, and as I said, we can use the laser beforehand to reduce and have an analgesic effect, so we get better tolerance to shockwave. However, if you have a look on the education portal of EMS, I have done earlier in the year, delivered a lecture talking about improving outcomes with shockwave therapy. And in this, I talked about a lot of the tools that I use to improve tolerance to shockwave. And I generally don't find too many problems with tolerance with patients. We then have to rehabilitate the patient, because laser and shockwave are not going to improve the load capacity in the tissue. The patient still needs to move. You have to take them through to that period. Often reducing the pain and allowing someone to start walking in less of a maladaptive way is in itself going to have an impact, because they're going to, just by walking, just by moving more normally, that is going to start to build some of the tolerance back up and that load tolerance in the tissue. But rehabilitation is obviously very important, and this can include progressive mobilization, proprioception exercise, using other machine-based therapies. This is really, whatever the clinician is most comfortable with, but it is important to build that load tolerance up. The electrophysical modalities such as laser and shockwave has an effect on tissue healing, has an effect on modulating pain, can help to get patients moving better, but ultimately rehabilitation is very important to get function back. And we can see from some of the research, and this is looking at utilizing shockwave or shockwave plus an eccentric loading program for Achilles mid-portion tendinopathy. In group 1, they receive 4 weeks of, we've got the first group, which is our shockwave group. So they receive 4 weeks of eccentric loading plus 3 weekly sessions of shockwave therapy. And the second group received just shockwave, the second group received just the loading program, so only the eccentric loading. And we can see that in the treatment groups, because both groups improved, but we had a significantly more improvement in the shockwave group. So rehabilitation is important. It has a therapeutic effect. When you combine this with something like shockwave, we can further enhance that result as well. This is looking at, for instance, plantar fasciopathy. And what we're looking at is in group 1, we have shockwave plus some physical therapy. And in this case, the physical therapy combined of sort of stretching exercises versus shockwave alone. And we see that in both groups, we get an improvement in their symptoms. However, the group that utilized the Shockwave plus the stretching exercises had a more significant impact. And this is what we recommend you use in practice. This isn't a replacement for your other clinical care. This is just to help maximize the improvements. We follow the patient up and make sure that we've achieved that outcome that we were looking at. And this comes down to, one, having preset those expectations early on, and also having some objective measures. So having things in your notes like pain scale, range of motion, those things, because patients, as they get better, can often forget how bad they were when they originally saw you. So I often like to, in that follow-up appointment, go back to your initial assessment and start talking to the patient. I use things like to measure muscle strength, dynamometers, so you can measure how much strength does the person have and you can compare it. You can use range of motions, you can use functional testing. All those sort of things are really helpful when you sit down at the end and say, okay, well, where were we and where are we now? And the patient can see where that's at, because it is often difficult if you've had pain for a long time and the treatment might have gone for 6 weeks. You sometimes forget as you're getting better what it was like. It's a little bit like, in the first, say, 6 months after having potentially a surgical, an operation, you're often very aware of that. 3 years later, it's hard to really even put yourself back into that position and understand the implications and the considerable impact it had on your life. So what we're going to do, I'm going to move on to a few case studies now. And I think these case studies sort of highlight, and these are cases where I've used just the laser on its own. What I think both of them highlight is we see people and we've got this concept of nociceptive neuroplastic pain, I think, is a really important concept. And what we're talking about when we refer to sort of neuroplastic pain is that we know that 30 years ago, the brain we used to believe was just hardwired. We know with neuroplasticity that the brain has the ability to create new pathways. And this has huge implications in terms of patients that have had injuries to the central nervous system, such as a stroke, etc. Our brains can rewire and reconfigure themselves. The same thing can happen with pain. We can develop maladaptive pathways, and that same adaptive mechanism, neuroplasticity, can help to reinforce and consolidate pain pathways as well. And I believe as a clinician, we see these patients all the time, and they occur on a spectrum. We have things like complex regional pain syndrome, which can be very severe and debilitating. But we see patients on the way on various spectrums of that sort of chronic pain syndrome. And being able to identify these patients and intervening early on can have a huge implication in terms of reducing long-term disability and the considerable impacts this has on people's livelihoods, lives, families, etc. So the first patient here, a 45-year-old female, she is married with 2 young children and she works part-time as an executive assistant. She presents, she also has a history of severe debilitating migraines, who she is under a specialist for. She's on medication for migraine, she's on medication for breakthrough migraines, and also has injection therapies as well, such as Botox, to manage that. But these can be very disabling, and she's suffered them her whole life. She also has anxiety and depression. So she presents following chasing her kids around the park. She's had a fall and she's sprained her ankle. She's been unable to walk. She presents unable to weight bear. There's extensive swelling and edema. She also reports nocturnal pain. So generally this sort of physical exam, the first thing I ask when a patient presents like this is, do you have nocturnal pain? Because generally if the patient has had pain that's been keeping them up at night, I'm very suspicious that there's a fracture. In her case, I ultrasounded her in the clinic. we had an ankle joint effusion, and we have this avulsion fracture. So we've got basically off the tip of her fibula, we have a small cortical break down here. It's difficult probably to see online, but we have a little chip of bone that's come off. We can see on the ultrasound, we've got an effusive dome where we've got a small hematoma. We have a cortical break. We've got some acoustic shadowing on the ultrasound, so it's consistent with bone. So the diagnosis was she'd also had an injury, I think a partial thickness tear to the ATFL and the CFL. So this patient has basically grade 2 tear to ATFL, CFL. She has an avulsion fracture of the tip of the lateral malleolus. Now, this is a condition that in general, when it comes to immobilizing patients, it's really important that we don't over immobilize. And one of the pet hates that I have is the overutilization of things like moon boots for prolonged periods of time for indications that don't need them. Generally, in an injury like this, I will put the patient into a moon boot for a period of time if they're unable to walk. If the patient's if the patient's ambulating reasonably well, we have a reasonably stable fracture, and these should be managed like an ankle sprain effectively. But probably just a more severe one, so they may need some more intervention, but I'll generally manage these patients in a brace. However, this patient did have quite considerable pain and was unable to walk, so I did put her into a moon boot. She was still in a lot of pain. She was still requiring, she was taking her opioid analgesics, which she utilizes for her migraines as breakthrough pain. She was utilizing that very frequently. It was interrupting her sleep. So after about a week, I wasn't happy. I did change her medication and said, listen, let's try and stop with the opioids, because generally you don't need them for an injury like this. If the patient is satisfactorily immobilized, there really shouldn't be a whole lot of pain that goes along with that. So I did put her into a soft sort of jello cast for a period of time along with the moon boot. This did help, but she was still requiring analgesics. As she came out of that, her pain was still significantly out of sync with where an injury like this should be. As clinicians that see these sort of injuries very frequently, you should have a range that's normal in terms of a normal response. Now, this patient's response was significantly more severe than that. So in this case, even despite having utilized a lot of the things that I would typically use in these acute settings, patients still had a lot of pain, was still taking opioids. And this is where we started the laser therapy. And the laser had a really significant improvement. We were able to get her off her opioids within the week that we started laser. We did start to see some improvements in terms of swelling. It still took time. It took time. And I think the really important thing with laser and with these particular patients is much of it is counseling, because these patients can start to catastrophize their pain. And it's important when you're talking with them that a lot of it is, it's important to understand their pattern of thinking. And this particular patient was sort of catastrophizing, thinking about the implications that it was having in terms of whether she would be able to run around with the kids down the track, all those sort of things. But then the injury itself was creating stress in her relationship. It was creating stress around her ability to parent, which was creating stress in terms of occupational, because she was having even more trouble. When you're in pain, you're just less able to cope with those sort of things like kids and work and all those sort of external stresses. So it's really important. I think the laser really provided that window, one, to have a therapeutic effect, but two, to actually be able to talk to these patients and to identify when that's occurring and intervene and actually start to reframe and teach them about how to frame the injury, listen to them. But it is important to sort of pull them up when they are starting to go, down a bit of a dark path in terms of, being super hyper focused on the injury itself and losing sight of the other important things in their life. The second case study is a patient who I'd known and I've treated her for, again, a non-specific ankle. It was a non-specific lateral ankle problem. And despite extensive investigation, consultation with multiple practitioners of different disciplines, consultation with multiple surgeons, there was not really a firm diagnosis. There was a few issues with the ankle, but it didn't represent the degree of pain that the patient had. Now, the injury that I saw her for with the laser was different. She actually had previously undergone a arthroplasty of her big toe joint to clean up some osteoarthritis, some spurring. Now, she had some complications following that. Surgery didn't go very well. They probably immobilized her a bit too long, and effectively the joint was pretty ankylosed. It wasn't moving very much. Now, she elected to progress, and her history includes, again, anxiety, depression, and she had that history of chronic pain. That injury that I saw her for and dealt and spent a lot of time helping her overcome, that was, she was in pain for 18 months there, and I probably spent a good 12 months with her, seeing her pretty frequently. Much more frequently than I would see most patients, because and a lot of the time we really just sat there and talked, and I had to it's almost holding their hand to a degree. Protected, utilizing various bracing and then removing that stuff. You don't want to keep these people immobilized for any longer than needed, because that can actually further contribute to it. So these are not the sort of people you want to put in moon boots for 12 weeks. I think it's extremely negligent to put people with things like heel pain without a real indication for a moon boot for 12 weeks, because these patients that are prone to chronic pain, it creates a massive amplification of their pain. It's very difficult to get them out of that. And then what happens is they tend to be very vulnerable in the medical system, because the more you complain to doctors and surgeons, the more the hierarchy and the treatment ladder starts to increase. And as you move up the hierarchy of treatments, they generally start to become more invasive, and the likelihood of complications and adverse effects increases. So this particular patient underwent an interpositional arthroplasty, which is an operation where basically it's an alternative to a joint fusion, where the joint is removed. So the chondral surface is removed. The remaining joint capsule is then stitched or placed into position of the joint, and that will heal in like a fibrosed way and create a fibrous joint. So it still allows for some movement at the joint, but it's turning a synovial joint into a fibrous one. The recovery does tend to be a bit longer compared to a fusion, where the joint's removed and the two bits of bone are just basically stuck together with a pin or a screw until it heals. But from the functional point of view, the functional outcomes are often better with the interpositional arthroplasty. Now, this patient, she presented to me sort of, even while in that initial post-operative period, she presented having trouble with the dressings. So I did have to redress it, because there was, it was a bit too tight, and that was keeping her up at night. Just the dressing she didn't find comfortable. Again, very anxious and very, very focused on the pain. So when I saw her, she was really very distressed. She wasn't sleeping properly. She was hyperfixated on the pain. She had severe pain. It wasn't being managed very well with pain medication. She had significant swelling, difficulty walking. She wasn't walking on that foot in a significant way. It was very, very antalgic. Difficulty sleeping, which is further contributing to her pain as well. But from a surgical point of view, she was where she should be at that point. So surgically, everything was healing up really well. There was no signs of post-operative complications. There's no infection. There's a good sort of surgical, in terms of the amount of healing, the skin was looking pretty well. There was no signs of infection or any post-operative complications at that stage, but the patient still wasn't coping very well. In her case, I used laser treatment on her, one to help with pain and also the swelling, which is important. Now, the first session I did with her, I received this email literally, that night, a few hours later. And in the email, she basically said, look, hi, James, I wanted to let you know that you worked magic yesterday. I don't know if it was the laser, but by the time I got home and since, I've been so much better. More improvement in 2 hours than I've had in 5 weeks since I had the operation. I've been up doing stuff most of the day. My swelling has gone down enough that I'm able to wear my original shoes. So one of the reasons she actually come to that appointment, she come with new shoes because she couldn't fit into her existing shoes, and she was all distressed about that as well. And so she's out buying new shoes that are 2 sizes too big because she can't fit her shoe into normal shoe. And she's at that time where the surgeon, with this sort of operation, you don't want to keep the patient immobilized for longer than they need to, because the whole aim of the operation is to encourage movement of that joint. So if you keep the patient in a stiff position, we're not going to get a very good functional results. The patient needs to be able to move after the operation. And in this case, her degree of pain was really affecting that. And laser was a really useful tool for her to be able to basically help with her rehabilitation, because you can't do exercise and you can't move on to physiotherapy if you're still in serious pain. You just can't get people to move those joints and to get significant improvement. She needs to be able to get to that point where we could do some gentle mobilization, that sort of stuff, before you can really progress with rehabilitation, which is really important in the long run. So my take-home message for this is, I think as primary healthcare professionals, we see these patients who are developing these chronic pain syndromes all the time. You need to take note when you've got a patient that's experiencing that has some of those risk factors, and you're starting to notice either they're catastrophizing that pain, they're developing maladaptive strategies to cope with pain, or that pain is becoming really out of sync with where it should be for someone with a similar type injury. Because intervening early in the course and utilizing things like laser, and I don't really care what sort of modalities, it's really, you've got to throw everything at this, because if you can cause some if you can desensitize them, you switch off some of that input into the central nervous system, some of those pain pathways. Once they become very consolidated and patients then move on to be diagnosed with things like complex regional pain syndrome, it's very, very difficult to unwind that, because those neural plasticity and those pain pathways become very entrenched. And long after the actual injury that caused the problem is healed, those pain pathways persist. And when patients are diagnosed with things like complex regional pain syndrome, it often takes a considerable input with, a multidisciplinary team with psychiatrists, psychologists, pain management doctors, physiotherapists, occupational therapists. There's a lot of work, and the treatment often involves reframing the pain, not fixing it. It's about learning how to cope, reframing, learning other adaptive ways of managing it. But I really do think that as clinicians, it's important in these patients to act really early, because that's when you can actually sort of change the course. And once that becomes entrenched, chronic pain has a huge impact on people's lives. It affects their mental health, it affects their families, it affects their ability to work. And this all has a really negative effect on people. It affects marriages and things like that. So I really do believe it's extremely important to act early in these patients. And they've been the patients that I've identified are starting to head down that pathway. They're the ones that I think the laser has had the most profound effect that I've seen. I've also used the laser on, patients with sort of heel pain before shockwave therapy, or used it for patients with, plantar fascial tears where there's significant swelling and inflammation. I've also used it in elite athletes as well that have had injuries where they are looking to sort of maximize their recovery. They need to get back on the field. They want to, improve, reduce swelling. They want to get back into their rehab exercises so that they can start to progress to getting back onto field. So that's that's really it for tonight. We'll take some questions. But yeah, I hope that was enjoyable.